Swayam Prabha. Digital India. Educated India.
Hello, I am Dr. Medora D'Souza Dias from the Goa Medical College. The topic I am presenting to you today is the ankle joint and subtalar joints. Let's look at some of the clinical aspects of ankle and subtalar joints. We will be covering in today's lecture talar fractures, foot drop, ankle fractures and congenital clubfoot among the various clinical aspects. What is the ankle? The ankle is a region that connects the leg with the foot. If you look at the ankle from the posterior aspect, you see the tendocalcaneus posteriorly, which is prominently seen, and on either side you get two bony prominences. The medial bony prominence is the medial malleolus. The lateral bony prominence is the lateral malleolus. This is the surface anatomy of the ankle. The segments of the foot. The forefoot is made up of the metatarsals and the phalanges. The midfoot is made up of the navicular, cuboid and the three cuneiform bones, and the hindfoot is made up of the talus and the calcaneus. Movements of the foot. The movements of the foot that occur at the ankle joint are plantar flexion and dorsiflexion. Normally, the ankle is in the neutral anatomical position where the foot makes an angle of 90 degrees with the leg. In plantar flexion, this angulation is increased wherein the toes point downwards and the heel is upwards. In the opposite movement, which is called dorsiflexion, the toes are moving upwards and the angulation between the foot and the leg becomes less. The axis of this movement occurs passing through the tips of the two malleoli, and this movement of dorsiflexion and plantar flexion occurs at the all-important ankle joint. There are other movements which are associated with the foot, those being inversion and eversion. If you look at these pictures here, you can see inversion is an inward turning where the sole of the foot faces medially. You also notice that the lateral border of the foot touches the ground, whereas the medial border is elevated. Inversion of the foot or turning inwards is a movement that takes place at the subtalar joint, not at the ankle joint. Along with inversion, there is another movement that takes place called supination. In supination, the head of the first metatarsal lies at a higher level and the head of the fifth metatarsal lies at a lower level touching the ground. If you look at eversion, which is a movement where the sole of foot turns outwards, this movement lifts the lateral border of foot and brings the medial border of foot closer to the ground. Eversion is a movement that is associated with pronation. In pronation, the head of the first metatarsal touches the ground, whereas the head of the fifth metatarsal is elevated. Pronation and supination are movements between the forefoot and the midfoot, and these movements cannot take place independent of inversion and eversion. So, whenever there is inversion and eversion, there is an associated supination and pronation taking part at the same time. The ankle joint is a uniaxial hinge variety of synovial joint between the talus and the tibia and fibula. It allows hinge-like dorsiflexion and plantar flexion of the foot on the leg. The distal end of the fibula is firmly attached to the tibia by strong ligaments called the interosseous, the anterior and posterior tibiofibular ligaments. Together, the tibia and fibula create a deep bracket-shaped socket in which the upper expanded part of talus rocks around a transverse axis. The articular part of talus is called the trochlea tali, shaped like a short half cylinder on its flat side, one end facing laterally, the other end facing medially. It fits into the bracket-shaped socket formed by the distal ends of tibia and fibula. The bony components of the ankle joint include the roof of the socket formed by the undersurface of distal tibia and fibula, the medial side formed by the inner aspect of the medial malleolus of tibia, the longer lateral side formed by the lateral malleolus of fibula. These surfaces are covered by hyaline cartilage. Let us look at the Tibiofibular Syndesmosis. A syndesmosis is an immovable joint which is very strong and fibrous between two bones. The joint that you see here between the lower ends of the tibia and the lower end of the fibula is a syndesmosis, and this is the ligament of this joint, the inferior tibiofibular ligament, also called the tibiofibular interosseous ligament. This ligament is very strong and it prevents the two bones from separating, especially when there are strains placed on the ankle and there is a tendency of the ankle to dislocate. It is the tibiofibular syndesmosis that maintains the integrity and protects the stability of the ankle joint. The trochlear surface of the talus is wider anteriorly and narrower posteriorly. So, the talus fits well into the mortise formed by the tibia and malleoli when the foot is dorsiflexed rather than plantar flexed. That is why the ankle joint is more stable with the foot in dorsiflexion. Let us look at the ligaments around the ankle joint. We all know that ligaments are protective factors for any joint and prevent any abnormal movements at the joint and help the joint to function properly. The ligaments of the ankle joint begin with a thin fibrous capsule. This capsule is very weak anteriorly and posteriorly, but on either side it is strengthened by collateral ligaments. These are the lateral and medial collateral ligaments. If you look here, you can see this is the lower end of fibula, and this lower end of fibula is attached to the talus and the calcaneus by the lateral collateral ligaments. Whereas on the medial side, the tibia is attached to the talus and calcaneus by the medial collateral ligaments. The medial collateral ligaments are very strong and they are triangular in shape. So, the medial collateral ligaments are also called the deltoid ligament. These ligaments maintain the integrity of the ankle joint in the various movements of the foot and stabilize it. Some of these ligaments are so strong that sometimes instead of a ligament tearing in an ankle joint injury, the bones attached to the ligaments break, like the lateral malleolus of the fibula and the medial malleolus of the tibia. We will see this as we proceed with our topic for today. Let's now study more details about these collateral ligaments of the ankle joint. The first is the all-important deltoid ligament. I already told you, if you look here, you can see the shape of the deltoid ligament. It is triangular. It's called the medial collateral ligament. It's large, it's strong. It has an apex attached above to the medial malleolus of tibia, and the base fans out to be attached to the navicular, the talus and the calcaneus bones. Since it has a broad base, this deltoid ligament is divided into 4 parts. The 4 parts are the tibionavicular part, so between the tibia and the navicular bone, the tibiocalcaneal part, the posterior tibiotalar part, and the anterior tibiotalar, which is deep to the tibionavicular part. These 4 parts of the deltoid ligament make this ligament functionally very strong so that it can stabilize the ankle joint. Let's now look at the lateral collateral ligaments. These lateral collateral ligaments attach the lateral malleolus, which is the lower end of fibula, to the talus and calcaneus. They are the anterior talofibular ligament. It is short and it attaches the lateral malleolus to the talus, and there is the posterior talofibular ligament which runs from the fibula to the talus. Lower down you can see a little longer Calcaneocuboid ligament. This attaches the fibula's lateral malleolus to the calcaneus. The ankle joint is a synovial joint of the hinge variety, and so as every synovial joint, it also has a lining of synovial membrane. But remember, there is one special feature of this synovial membrane. If you look here, the synovial membrane lines this joint, but it dips into the space between the lower ends of tibia and fibula and projects into the space between the 2 bones, just below the interosseous tibiofibular ligament. The nerve supply of the ankle joint is from the deep peroneal and tibial nerves. The movements of the ankle joint we already mentioned. The movements are dorsiflexion and plantar flexion. Remember, a hinge joint has only one axis. If there is only one axis, there will be only one type of movement. So, the movement is dorsiflexion or plantar flexion. The range of plantar flexion is more, it is about 55 degrees, whereas the range of dorsiflexion is much less, about 35 degrees. Plantar flexion is limited by the ligaments on the anterior side, by the tension of the tendons on the anterior side and the anterior portions of the capsule. Dorsiflexion is limited by tensions of the posterior tendons like tendocalcaneus and the posterior capsule, and that is why you find that dorsiflexion has a less range of movement than plantar flexion. What are all the muscles that create these movements of dorsiflexion and plantar flexion? The prime movers in plantar flexion, 95% is by the gastrocnemius and soleus, which are collectively called tricepsurae. A negligible 5% of movement takes place by plantaris, flexor hallucis longus, flexor digitorum longus and peroneus longus. Dorsiflexion prime movers are the tibialis anterior, extensor digitorum longus, peroneus tertius and extensor hallucis longus. In simple terms, we just have to remember that all the tendons that lie anterior to the ankle joint are going to provide dorsiflexion, whereas the tendons passing posterior to the ankle joint will provide plantar flexion. Structures limiting movements of the ankle joint. Plantar flexion is limited by anterior ligaments like the talofibular, anterior part of deltoid ligament, anterior joint capsule, tension of dorsiflexors of the ankle. Dorsiflexion is limited by posterior ligaments, posterior parts of deltoid, calcaneofibular, posterior talofibular, posterior joint capsule, contacts of the talus with the tibia, and tension of plantar flexors of the ankle. To summarize what we have just studied, we are talking about the ankle joint. The ankle joint is a junction between the leg and the foot. It is normally at an angle of 90 degrees and it is a hinge type of synovial joint, allowing movements of dorsiflexion where the toes are raised up and plantar flexion where the toes point downwards. The movements take place at the ankle joint with an axis passing through the tips of the two malleoli. The ankle joint, like every synovial joint, has got a thin fibrous capsule, thin anteriorly and posteriorly, but reinforced on either side by the medial and lateral collateral ligaments. The medial collateral ligament is very large, it is triangular, so it is called the deltoid ligament, and it is made up of 4 parts: the tibionavicular, tibiocalcaneal, posterior and anterior tibiotalar parts. The lateral collateral ligament is made up of 3 parts. It is smaller and it has anterior and posterior talofibular and the calcaneofibular ligament. The movements of the ankle joint are a plantar flexion and dorsiflexion of the foot. The intertarsal joints. There are numerous synovial joints between the various tarsal bones between the talus, calcaneus, navicular, cuboid and the cuneiform bones. The movements that take place between these bones are inversion, eversion, pronation and supination. Let us look here at this picture. This picture shows a foot in inversion associated with supination. Inversion is turning the sole of the foot inwards and the lateral border of foot depresses, the medial border of foot elevates. Eversion is the opposite movement where the sole turns outwards, and this is associated with pronation where the medial border of foot touches the ground and the lateral border of foot is elevated. These movements take place primarily at the subtalar joints. The subtalar joint is a joint between the talus and calcaneus, and the axis is very different from that of the ankle joint. The axis of the subtalar joint passes in an antero-posterior direction and downwards and medially. Intertarsal joints allow pronation and supination, which helps the foot to maintain contact with the ground when standing on irregular surfaces. Most of the movements take place at the subtalar and the transverse tarsal joints. The subtalar joint is between the posterior facets of talus and calcaneus, so it is also called the posterior talocalcaneal joint. The transverse tarsal joint is a joint between the talus, calcaneus and navicular medially and the calcaneus and cuboid laterally. So, these are called the talocalcaneo-navicular joint and the calcaneocuboid joint. The nerve to supply to these joints is by the deep branch of the peroneal nerve and medial and lateral plantar nerves. The subtalar joint, as we said, it is between the large posterior facet of the talus and the large posterior facet of the calcaneus. It encloses a space called a sinus tarsi, and this sinus tarsi has a ligament passing between the two bones called the interosseous ligament. The talocalcaneal joint allows gliding and rotation to take place which is a movement involved in inversion and eversion. The ligaments of the subtalar joint are the capsule, the lateral, medial, posterior and interosseous portions of the ligaments, as well as the interosseous ligaments of the tarsal sinus. The subtalar joint, as I told you, has an axis passing through it from anterior to posterior and slightly medially and downwards, and it resembles the movement of a mitted hinge. A mitted hinge has a similar movement as that of the subtalar joints. The movements have a horizontal component which involves inversion and eversion, and a vertical component which involves tibial rotation. The transverse tarsal joint is a link between the midfoot and the hindfoot. It lies in a transverse plane and it lies between the posterior components being the talus and calcaneus and the anterior components being the navicular and cuboid. The transverse tarsal joint is made up of two joints, the medial placed talo-calcaneonavicular joint and the more laterally placed Calcaneocuboid joint. The talo-calcaneonavicular joint is much more complex than the simple Calcaneocuboid joint. Let us talk about the talo-calcaneonavicular joint. It is a ball and socket joint, the ball being the head of the talus and the socket formed by the navicular and calcaneus anterior facet. It is supported from below by a very strong ligament on the medial side called the spring ligament. It allows a gliding and rotational movement to take place, which gives you movements of inversion and eversion. It also participates in the movements of pronation and supination. The capsule of the talo-calcaneonavicular joint is reinforced by the posterior interosseous talocalcaneal ligament, superiorly by the talo-calcaneonavicular ligament, and inferiorly by the spring ligament, also called the plantar calcaneonavicular ligament. The Calcaneocuboid joint, this is the lateral component of the transverse tarsal joint, and the facet on the anterior surface of calcaneus articulates with the corresponding facet of the cuboid. It allows a sliding and rotating movement to take place for inversion and eversion of the foot, as well as pronation and supination of forefoot on the hind foot. The Calcaneocuboid joint is strengthened by the plantar ligaments. The plantar ligament is the long plantar and short plantar. These ligaments pass from the calcaneus to the cuboid on the inferior aspect. Subtalar and transverse tarsal joints have muscles which move them. The prime movers are the inverters are the tibialis anterior and posterior, which also cause adduction and supination of forefoot, flexor hallucis longus, flexor digitorum longus, and the triceps surae in an already plantar flexed foot. Everters are peroneus longus and brevis, and the tertius, extensor digitorum longus. Remember that inverters and everters always act in a combination to bring about these movements at the subtalar and transverse tarsal joints. Let us summarize the subtalar joints and their various movements. The subtalar and transverse tarsal joint. The transverse tarsal joint has two components, the medial talocalcaneonavicular part and the lateral calcaneocuboid part. The subtalar joint is between the posterior corresponding facets of the talus above and the calcaneus below. The movements at these joints are of inversion, eversion, pronation, supination and a slight adduction and adduction of the forefoot on the midfoot. The talocalcaneonavicular joint is a ball and socket type of joint which allows movements of the talus head being the ball and the socket formed by the navicular and calcaneal anterior facet. The Calcaneocuboid is a plain synovial joint between the calcaneus and the cuboid, allowing a sliding movement to take place. The ligaments of the Calcaneocuboid are the long and short plantar ligaments. You would also notice that anterior and posterior to the ankle joint is surrounded by various tendons which are kept in place by fibrous bands called retinacula. Let's study these retinacula in more detail. First, let's look at the flexor retinaculum. You can see in this figure here the green structure which runs on the medial side of the ankle joint. It's a strap-like layer from the medial malleolus of tibia to the calcaneus. It covers something called the tarsal tunnel, and there are tendons that pass down from the posterior compartment of the leg and they continue into the sole. There are septae in this tarsal tunnel and each of the tendons has a separate passage. Let's look at the structures passing through the tarsal tunnel from medial to lateral. First is the tibialis posterior tendon, then is the flexor digitorum longus, then comes the neurovascular bundle, that is the posterior tibial vessels with the tibial nerve, and last is the flexor hallucis longus tendon. Flexor hallucis longus tendon is a long tendon that extends right up to the first toe. The pulse of the posterior tibial artery can be felt in this region posterior to the ankle, and it's one of the peripheral pulses which is examined in the living patient. The next is the extensor retinaculum. As the name implies, it's a fibrous band on the extensor aspect and it is divided into a superior part and an inferior part. So, there is superior extensor retinaculum between the tibia and fibula and an inferior extensor retinaculum between the tibia and the plantar aspect and the calcaneus. So, the superior extensor retinaculum is attached to the tibia and fibula. These two retinacula keep the extensor tendons in place during the various movements of the ankle joint. The inferior extensor retinaculum is more complex, being a Y-shaped band, and it also has an attachment to the plantar aponeurosis. What are the structures passing through the extensor retinaculum? The structures passing deep to the extensor retinaculum from medial to lateral are the tibialis anterior tendon, the extensor hallucis longus tendons, the dorsalis pedis artery, extensor digitorum longus tendons, and last is a peroneus tertius. The dorsalis pedis is another peripheral pulse that can be examined between the tendons of extensor digitorum longus and extensor hallucis longus. The fibular or peroneal retinacula, these are two in number, superior fibular retinaculum and inferior fibular retinaculum, and these keep the tendons of the peroneus brevis and peroneus longus in place as they pass posterior to the lateral malleolus. They are attached from the lateral malleolus to the calcaneus and they keep these tendons in place as they pass to their site of insertion. Let us summarize what we have studied about the retinacula. The flexor retinaculum is a single band which lies on the medial side of the ankle joint between the medial malleolus and the calcaneus. It keeps the flexor tendons as well as the tibialis posterior as they are passing from the posterior compartment of leg into the sole of the foot. The structures that pass under cover of this tarsal tunnel is the tibialis posterior, flexor digitorum longus, flexor hallucis longus, as well as the neurovascular bundle, the posterior tibial vessels and the tibial nerve. Remember that the pulse of the posterior tibial vessels can be felt at this site, posterior to the medial malleolus of tibia. Then we looked at the extensor retinaculum. It is a little more complex because it has a superior band between tibia and fibula and an inferior Y-shaped band between the medial malleolus calcaneus and the plantar aponeurosis. Tendons passing under it are the extensor tendons as well as tibialis anterior. Dorsalis spurious pulse can also be felt as this artery traverses posterior to this extensor retinaculum. Laterally, we found and studied the fibular retinaculum. There are superior fibular retinaculum and inferior fibular retinaculum, keeping tendons of peroneus longus and peroneus brevis in place. Let us now proceed to study the clinical anatomy of the ankle and subtalar joints. Congenital clubfoot, also called talipes, where the foot of a newborn baby is inturned, and this could be divided into various types like talipes calcaneovalgus, where the foot is dorsiflexed at the ankle joint and everted at metatarsal joints, or like you can see here, talipes equinovarus, where the foot is plantar flexed at the ankle joint and inverted at the mid-tarsal joints. It could be unilateral or bilateral, and it interferes with the walking ability of the child. So, it needs to be orthopedically treated, like you may need splinting, casting, or in severe cases you might even require surgery. The deformity can be seen above here, and if you look at the inner structures, you notice there is a shortening of the tendons that creates the interning of the feet. Another deformity is called metatarsus varus. The forefoot is adducted on the rear portion of foot. This can be corrected by manipulation followed by splinting. Foot drop is another clinical defect where the person is not able to dorsiflex the foot at the ankle, and in order to prevent the foot drop is the inability to dorsiflex the foot at the ankle. So, in order to prevent the foot from banging the ground while walking, the person tends to lift the foot up by flexing the hip joint and knee joint and then taking a step. This is called the steppage gait, wherein the person raises the foot up by raising the knees and flexing the hips. It is due to injury to the common peroneal nerve which crosses the fibular neck, where it lies superficially and it is vulnerable to injury here, or it could be due to discompression of lumbar nerves contributing to the common peroneal nerve. Ankle injuries. You often hear, "Oh, I've sprained my ankle." It's quite a common thing that you hear nowadays, especially with everyone wearing high heel shoes. These are some of the hazards of wearing high heels. They might look good, but they are practically not very. If you see in this picture here, a high heel shoe increases the stress on the ankle joint. Ankle joint is a ring, a fibro-osseous ring, having an upper part between the distal ends of tibia and fibula, the bottom of the ring being the talus, and the sides formed by the two malleoli. This ankle joint is prone to sprains and fractures. Ankle sprains are very common among athletic injuries, makes up about 30 to 40% of all athletic injuries. The ligaments get overstretched, but usually they do not totally rupture. The amount of strain will depend on the intensity of damage to the ligaments. Mostly the injury is a forced inversion injury. Signs and symptoms involve ankle pain, swelling, bruising and instability of the ankle joint. What you see here in this slide is a test called the anterior drawer test. The examiner tries to draw the ankle and the foot forwards by holding the tibia and fibula in place. If the foot moves forwards, that shows that there is some amount of instability of the ankle joint, and it is called a positive drawer test for ankle joint. Here you can see various types of ankle fractures. Now, a type of ankle fracture will depend on whether it is an inversion injury or an eversion injury. In inversion injuries, where the foot is forced inwards, the lower portion of foot is forced inwards, the upper part gets pushed outwards. This leads to strain on the lateral ligaments and sometimes even shearing off of the lower end of fibula. In eversion injury, where the heel is forced outwards and the upper portion of foot is forced inwards, there can be a strain of the medial malleolus, medial collateral ligament or deltoid ligament, and again it could shear off the lower end of fibula. Sometimes you will get an ankle injury of the ligaments only. Now, this kind of injury is not seen on X-ray because the bony components are not involved, but there may be tears and bruising and damage to the ligaments, which is dangerous because it cannot be seen on an X-ray. Potts fracture dislocation of the ankle. This is a special type of fracture wherein there is abduction and external rotation of the lower limb. For example, a patient walking on a ground and his foot gets stuck in a rabbit hole. The body and the tibia are internally rotated while the foot is rigidly held in the hole on the ground. First degree Potts fracture, the talus moves laterally and shears off the lateral malleolus. In a more severe second degree, there is pull on the strong medial ligament, tearing off the medial malleolus. A further stronger variety is the third degree, where even the tibia moves forwards, shearing off the posterior end of tibia against the talus. Daniel Weber classified various types of the fractures of ankle joint depending on the height of fracture of the fibula. He said that type A is fibula fracturing below the tibiotalar joint, type B is fracturing at the level of the tibiotalar joint, and type C is fracturing much higher than the level of the tibiotalar joint. Type C will involve the syndesmotic ligament of the inferior tibiofibular joint. There are rules whenever you example an ankle joint injury. These are called the Ottawa ankle rules. They assist the clinician in determining the severity of an ankle sprain or an ankle fracture or an ankle injury. An ankle X-ray series is required if there is ankle pain and any of the following: bone tenderness along distal 6 centimeters of posterior tibia or fibula to the tips of medial and lateral malleolus, or inability to bear weight for 4 steps. You need a foot X-ray series if there is mid-foot pain with any of the following: bone tenderness at the base of 5th metatarsal or navicular and inability to bear weight for at least 4 steps. Talar fractures. Now, talar fractures are not very common, but they are dangerous because the head of talus receives its blood supply through intraosseous arteries. So, if there is a fracture of the talus at its neck, the head of the talus blood supply is going to get compromised and it is going to go through avascular necrosis. Avascular necrosis is a condition where the bone gets destroyed because of no blood supply when its blood supply is compromised, like a fracture through any part of the bone. Tibial nerve entrapment is a syndrome where the structures passing through the tarsal tunnel are trapped and there is edema leading to compression of the posterior tibial nerve and the tibial artery. sorry, I'll do this slide again. Tibial nerve entrapment is a clinical condition also called the tarsal tunnel syndrome. There is edema and tightness in the ankle involving synovial sheaths of tendons passing in the tarsal tunnel. There is heel pain because of compression of the tibial nerve and a pulling of the flexor retinaculum. The surgical approach of the ankle joint could be anterior or posterior, anteriorly between tendons of extensor hallucis and digitorum longus, posteriorly between the tendons of tibialis posterior and flexor digitorum laterally, or between the peroneus longus and brevis. Aspiration of the ankle joint can be done anterior to the lateral malleolus or in front of the medial malleolus. Let us do a final summary on today's topic. We have spoken about the ankle joint. It is a hinge type of synovial joint between the lower ends of tibia and fibula and the trochlea tali or the upper end of the talus. It permits a movement of dorsiflexion and plantar flexion with an axis passing through the tips of the two malleoli. The ankle joint has a capsule and a synovial membrane. The capsule is reinforced on either side by the medial and lateral collateral ligaments. The medial ligament is a strong deltoid ligament made up of 4 separate parts. The lateral ligament is the smaller fibular collateral ligament and it has 3 components. The subtalar joint is a joint between the posterior facets of the talus and calcaneus, and the subtalar joint along with the transverse tarsal joints are responsible for the movements of inversion, eversion, pronation, supination, adduction and abduction. The transverse tarsal joint is made up of 2 parts, the medial talocalcaneonavicular part, which is a ball and socket type of joint, and the lateral calcaneocuboid, which is a plane type of synovial joint. Together these joints with their ligaments help in the various movements of inversion, eversion, abduction, adduction, pronation and supination, which allow the person to maintain balance while walking even on uneven ground. All this puts a strain on the ankle joint which could lead to sprains or fractures. Sprains meaning the ligaments are stretched or partially torn or completely torn. Fractures will vary depending on the type of force, whether it is an inversion injury or an eversion injury. We also study today the relations of the ankle joint, the tendons passing anterior to it, kept in place by the extensor retinacula, lateral to it like the peroneal tendons kept in place by the fibular retinacula, and posteriorly and medially the flexor retinaculum with the tarsal tunnel keeping in place the flexor tendons which pass into the sole of foot. With this, I would like to end my topic for today. Thank you.